Good morning and welcome to Pediatric Grand Rounds. It's 7:30 and it's time to start our Grand Rounds. The CME code is in the chat box and we'll try to repeat it as many times as possible during the presentation. It's my great pleasure to introduce this morning's Grand Round speaker, Dr. Daniel Ranch, who is Clinical Associate Professor in the Division of Nephrology in the Department of Pediatrics at UT Health San Antonio. He currently serves as the Medical Director of Pediatric Kidney Transplantation for the University Health Transplant Institute and Manuel Carlos Alvarez Center for Transplantation, Hepatobiliary Surgery and Innovation. He is a Fellow of American Society for Transplantation, a designation which recognizes those members who have demonstrated both an exceptional commitment to the field of transplantation as well as outstanding service to the society. Dr. Ranch earned his Bachelor's of Science degree in microbiology and molecular genetics from the University of California in Los Angeles. He then received his medical degree from Chulalongkorn University in Bangkok, Thailand. He completed his pediatric residency training in Las Vegas, Nevada at the University of Nevada School of Medicine, and then his pediatric nephrology fellowship at the University of California, San Francisco. Dr. Ranch joined the UT Health San Antonio faculty in 2010, and his research has focused on improving long-term outcomes in pediatric transplantation and the care of adolescent and young adult kidney transplant patients. Dr. Ranch, thank you very much for accepting our invitation, and the floor is yours.
Thank you, Dr. Kamat, for that very nice introduction, and thank you, everyone, for joining this morning. My name is Danny Ranch, and I'll be talking about transplantation, pediatric kidney transplantation at our institution, partly to toot our own horn, but also to make sure that our own teammates here know all the great things that all of our divisions are doing for our institution. Because sometimes we're kind of siloed. Not everyone gets to see the great work that's happening behind the scenes. So I'll start with this first photo here. This is actually from 2020. And the Transplant Institute was celebrating its 5,000th transplant surgery, and they celebrated with an all-women surgical team, which is fantastic and historical. So that's why I put that there. So, all right, I do have a few disclosures, meaning that I probably have too many slides, a lot of content I want to go through, but I'm going to try and go through the first several slides quickly because I want to get to the meat of the talk. It was hard to do that without some background. So, but otherwise, I have no financial relations to disclose. I will be discussing some off-label medications, and all the patient images were used with permission. So, also another disclosure: I'm completely biased towards transplantation, having been a kidney donor myself. So everything I say, take with a little bit of a grain of salt, I guess. All right, so learning objectives for today will be I'll be reviewing the epidemiology and presentation of pediatric kidney disease in the country, briefly review the benefits of kidney transplantation and the process that our patients go through, and hopefully spend most of the time in the talk actually talking about what we've done for the field and what the future holds and what I hope to get our program involved in going forward. So pediatric kidney failure in the U.S. This is a pretty famous patient, Emmy. She came to us several years ago as a baby. She had presented to another hospital soon after birth with recurrent infections and sepsis, and they initially couldn't figure out why. And eventually someone noticed that, oh, she has a lot of protein in her urine, and coupled that with the fact that she had very low albumin levels that were persistent. And so came to us and finally was diagnosed with a congenital form of nephrotic syndrome, which is the cause of her kidney failure. So to give some background on kidney disease in the U.S., I do hear somebody's mic on. Sorry. It's a big but under-recognized problem. The estimates are currently that there are about 20 some odd million people in the country affected with any type of chronic kidney disease. But today we're talking about kidney failure. So there are about 800,000 people in the country with full kidney failure, Unfortunately, about 500,000 are on chronic dialysis. And the rest of those are either on either receive the transplant or on just palliative care, unfortunately. And not only that, there are about 100,000 new patients with end-stage kidney disease in each year in the country. And this map is showing the prevalence of end-stage kidney disease in the country. The dark areas represent a higher prevalence, and of course, down here in South Texas, we are one of the leaders in kidney failure, and hopefully something we'll fix in the future. In adults, the most common cause of kidney failure is diabetic kidney disease. We know that's a big problem, it's been an ongoing problem. But also other causes include hypertensive sclerosis, different forms of glomerulonephritis, and cystic kidney disease, like autosomal dominant polycystic kidney disease. And so a lot of these patients are on dialysis, and people might ask, well, why can't you just do dialysis? Because you're cleaning the blood, you're keeping them alive. And actually, unfortunately, dialysis is not a normal state, it's a chronic inflammatory state. We're probably providing just the bare minimum to keep people alive or healthy enough to get to transplant. So, and this day, I'm going to show a lot of data here from the United States Renal Data Systems, which is basically our registry for all patients on dialysis and transplant in this country. And this graph is showing that survival over time by modality, hemodialysis in this case, is much worse compared to those who receive the kidney transplant over time. So, and this has been shown. So you could please mute, please, if you just logged on. And this has been shown over and over again that transplant offers a significant survival advantage compared to dialysis, and that's why we promote transplant as a priority. When patients have kidney failure, most commonly they're dying from cardiovascular disease, most often arrhythmia and sudden cardiac arrest. And then with the advent of COVID-19 in 2020, that actually popped up as a common cause of death as well too. Also, just a quick note, dialysis, end-stage renal disease care is under Medicare and it's expensive, but it's been shown consistently that compared to chronic dialysis care, which say for hemodialysis is about $100,000 per person per year, kidney transplant after the initial surgical cost is much cheaper over time. So another reason we prioritize transplant care. So then if we know that transplant is better, why don't we just transplant everybody? Well, the problem is there's about 90,000 people in this country at any one time waiting for a kidney transplant. But so far to date, we're only doing about 25,000 transplants a year. So you can see that backlog. And what that translates into is that typically adults are waiting about 5 to 8 years on dialysis before they can get a transplant on the waiting list, depending on which area of the country you're in. Someone else say, well, why don't we do more living donor transplants, which I'll talk about later in the talk, which would be fantastic. But we're only doing about 6,000 living donor transplants per year. Also, we're adding about 40,000 new patients with kidney failure to the transplant waiting list every year. And the reason that list isn't going up faster is because people are dying every day waiting for a kidney transplant. So these are all barriers to, why can't we solve this problem? And then additionally, unfortunately, transplanted kidneys don't last forever. On average, they're lasting about 15 to 25 years, depending on the type of transplant. And so those patients, especially our kids, will need additional transplants in their lifetime. Let's see. So fortunately in kids, the numbers aren't as drastic. There's about 5,600 kids in the country living with kidney failure. And the good thing is the majority of them have a kidney transplant in gray here. The rest are on dialysis, but we prioritize our kids in terms of getting a transplant, especially on the waiting list, and which is why the numbers are different. And also there's less patients overall. Otherwise, in this country, we see about 800 new cases per year. And in Texas, that comes out to about 70 to 100 new cases per year on average. In kids, the causes of kidney failure are somewhat different from our adult counterparts. In kids, congenital anomalies of the kidney and urinary tract, meaning renal or urinary tract developmental abnormalities, are the most common cause of kidney failure, followed by glomerular disease such as FSGS, cystic or hereditary kidney disease such as autosomal recessive polycystic kidney disease, or your immune-related glomerular diseases like lupus-associated nephritis. And also, unfortunately, in kids with kidney failure, they're acting like old people. I say old people because I'm a pediatrician, right? That's how we talk to our patients. But unfortunately, when you have kidney failure, your mortality is higher than the general pediatric population, whether that's any type of dialysis, even transplant, which is provides a much better advantage, as I'll harp on over and over again, but it's still much higher than the general pediatric population. This data is over 10 years old, but it still holds true, unfortunately, where kids in our country typically in the general population pass away from accidents, homicides, suicides, but our patients on kidney failure die from older people diseases, cardiac disease, infections, cancer, with cardiac disease typically being the most common cause. And so people try to predict what would happen to these patients depending on their modality for treatment with kidney failure. And so in this country, if in the general population, after you're born, you're expected to live about into your 70s, right? However, if you are born as a child with kidney failure and you're on chronic dialysis, it's estimated that you only live into your 20s, which is ridiculous, right? Because that's compared to the lifespan of a healthy 50, 60-year-old. So how to improve that? And we found that transplant significantly is predicted to improve that survival into the 50s or 60s, which is great, but still worse than the general population. And that's why we're still actively working to find ways to improve our transplant care. And so the message typically is, I would say most, if not all, nephrologists believe that kidney transplantation should be the goal for all people with kidney failure. It's just, how do we overcome the barriers to achieving that goal? So this is little Emmy, that baby you saw earlier with the nephrotic kidney failure, and at a Halloween event at the hospital some years ago. And normal kid, right? So, and just a quick clinical pearl. So when do you suspect kidney disease in kids? When they come up when they come in the ER or hospital sick and they're not urinating and they're swollen, that's easy, right? That's easy to pick up. But what about the more subtle cases? So things you can watch for, especially out in the outpatient world, subtle signs that maybe there's something going on that could be caused by kidney disease. Unexplained failure to thrive typically can be a sign of probably some underlying metabolic acidosis not picked up. Persistent proteinuria typically is a harbinger of kidney disease, different from intermittent proteinuria. So that's why we also, when you send patients to us, we'll say, just recheck it. So, but actually, that's because that's what we're looking for, is how persistent, how abnormal is that finding. So unexplained hypertension. So hypertension that's not due to, say, being overweight or whatnot. Then positive family history sometimes can be clues that, this patient may have risk for certain genetic kidney diseases like Alport syndrome or autosomal dominant polycystic kidney disease. And sorry, my voice is shaking a little bit because it is now probably down to 50 degrees in my office. My space heater went out, so, but we'll push through. So, all right, so kidney transplant. So I'm just doing some background on kidney transplantation, and also I'm going to try and go a little bit quickly so I can get to the rest of the talk. But so there are obviously many people who have made giant contributions to the field of transplantation, but I'm just going to highlight a couple here. So Dr. Joseph Murray from Mass General, he performed the very first successful human kidney transplant in the 1950s. And and this is probably for the students and the residents. This is classical medicine, right? So he was a surgeon in the Army treating patients with burns back then, and he noticed that when he tried to do skin grafts for patients with severe burns, that a lot of them would reject them and they wouldn't take, and they wondered why. And then when he came back and joined Mass General, he actually joined a team that was working on trying to save people with kidney failure, because this is 1950s. There's no chronic dialysis, right? So, or it was only available for a select few. And their goal was to try and cure kidney disease. And they thought that transplantation was going to be the key way back in the 50s and 60s. So, and eventually he had a patient who had kidney failure, had a twin brother who was willing to donate, identical twin brothers willing to donate his kidney. And so went through a lot of, ethical dilemmas and whatnot, but eventually got him transplanted. And it worked. And this image here on the right shows Dr. Murray with the donor, Ronald, at the transplant games, which is basically Olympics for kidney donors, organ donors, 50 years later. And both were actually doing well. So very, very nice to see. And Dr. Murray actually won a Nobel Prize with the rest of the team in the 1990s. Additionally, Dr. Paul Terasaki from UCLA, he was actually a zoologist by training. and was studying the immune system and studying skin grafts initially in animal models, initially in baby chicks, trying to figure out why they wouldn't take. Right? So, and eventually, as he joined UCLA, was working with the Department of Surgery and trying to figure out, well, there's got to be something in the blood, something related to the immune system that's causing these rejections, and eventually figured out it was antibodies and the HLA antigen system. And he's the one who developed a very important test called the complement dependent cytotoxicity, or CDC assay, that helps us determine, is this donor and our patient going to be compatible by comparing their serum samples and looking for a reaction. So his discoveries were a huge step forward in providing safe kidney transplant for our patients. And then, of course, at our own institution, we have our own transplant pioneers too. If you don't know, on the left here, Dr. Glenn House, he the transplant surgeon, and he started our liver transplant program here back in the 90s. Also, him and Dr. Sigaro here on the right, they did the very first split liver transplant in the region here. And Dr. Sigaro, after spending who knows how many years leading our institution and then the UT system as a whole as chancellor, came back because he couldn't shake his love for taking care of kids and for surgery. So came back and got our pediatric liver transplant program going. And so these two gentlemen have really grown our transplant programs as a whole into our not only pediatric but adult kidney and lung transplant programs are nationally renowned, and our living liver donor program, especially on the adult side, is world renowned. So, and it's all due to their leadership and vision. All right, so very briefly, who actually can get a transplant when you know they're ready? So size is important because, when we're transplanting kidneys, the vast majority of our patients are getting one adult kidney. So it's one adult kidney going to a kid. So that adult kidney is typically about 10 to 12 centimeters in length, about 150, 200 grams in weight. And so the child has to be big enough to be able to receive that kidney. And also for the vessels to be large enough so that they can do their anastomosis safely. So we'll say the kid has to be the size of about a normal 1-year-old, which when you have your bone kidney failure is actually hard to get to. And statistically, most kids who start dialysis as a baby don't get to that size until they're 2 years old. So you can see that delay for getting a transplant. Also, you don't want to transplant too early because crappy kidney is still better than transplanted kidney with medications. And so we'll typically wait until the kidney function is getting down to below our level of what we call kidney failure or end-stage renal disease, which is a GFR of less than 15 milliliters per minute for body surface area. So you need to have your vaccinations up to date, and especially our live vaccines, because currently we don't believe it's safe to give live vaccines after solid organ transplantation, especially kidney transplantation. So it's important to get those in on time. Otherwise, the vast majority of our inactivated vaccines are safe to give before or after transplant. We screen for psychosocial concerns to make sure there's no barriers that might prevent a successful transplant, because you'd have to have your care afterwards, have to get your medications, to be able to drive here for your visits. So it's a pretty rigorous evaluation process. And then sometimes their underlying disease may warrant waiting time. So we have some immune condition that we want to die down, or they have urological disease that needs to be corrected surgically before it's safe to plug in the kidney. Now, some contraindications, and it says absolute here, but at least in pediatrics, typically no contraindications absolute. We're going to evaluate pretty much every case to make sure that we've explored every pathway to transplant for that child. But in general, if you have severe irreversible heart or lung disease, typically, obviously placing kidney in that environment is not going to work. Active or recent malignancy, and typically we want to see our patients who are cleared from a malignancy for at least 2 years. Some would say 3 years. Other terminal illness, which is changing all the time, right? We used to say patients with Duchenne's muscular dystrophy or spinal muscular atrophy would be contraindicated, but now there are potential treatments for that. So that that's changing over time. So then obviously active infection. So relative contraindications include severe obesity, unresolved psychosocial issues, special mental health disorders that aren't treated, and then rarely lack of vascular access. We've had some patients where they're born and they don't have normal intra-abdominal vasculature for kidney anastomosis. So, all right. So you go through that. You're ready for a kidney. when do we do it? What types of kidneys can you get? So the two ways you can get a kidney are either from the waiting list or from a living donor, which I'll talk about. And actually, at our center, at least, we do prioritize trying to get our patients transplanted right in that window where the kidneys are failing. GFR is less than 15, but they haven't started dialysis yet. And we hope to have them ready at that time to do what's called a preemptive transplant, meaning you're skipping dialysis. And we believe that the benefits are, one, you can avoid dialysis, right? If you talk to a parent who's had a child on home dialysis for a year, they'll tell you it's a horror, right? Waking up every night with the machine alarming and so forth. So trying to save them that pain if we can. And then at least through many observational studies, improved graft and patient survival. So that's something we continue to prioritize here at our center and other centers too. So, we prioritize living donation over a kidney from the waiting list, meaning a kidney from a healthy donor, which I'll have slides on later. But it's been shown time and time again, these are different decades of study from kidney transplant, and it's been shown that living donor transplants last longer over time compared to deceased donor, cadaveric donor transplants. And that's just basically every decade of study that we had. So that's why living donation is also very strongly promoted nowadays for transplantation. But otherwise, if you're a child and you don't have a living donor, that's okay. We can still get a kidney from the waiting list. And fortunately, different from the adults where their typical wait time is 5 to 8 years on dialysis, our kids in this country probably wait about 6 months on average. And that's going to depend on other factors. Please mute if you just logged on. That's going to depend on other factors such as blood type, time on dialysis, your age. This pan-reactive antibody, or PRA, is a test to help predict reactivity with other potential donors in your area or community. And so basically the higher that number, the higher it is to match with a potential donor in the donor pool. And then where your center is located, because some centers are busier and others have a higher population, larger waiting lists and so forth. For the surgical side, kidneys in adults and older kids typically are placed actually what's called extra retroperitoneally in the iliac fossa, and showing this image on the left here. So you see this hockey stick looking incision in the lower quadrant, and the kidney is actually placed in the iliac fossa outside the peritoneal cavity. The vessels are hooked up to the external iliac vessels for the most part, and then the ureter is plugged in the bladder. And they found this type of placement. With this type of placement, people recover much faster because you're not in the peritoneal cavity. There's minimal to no bowel stunning, so the recovery is really quick. So I would say on average, the adult patients, they're in and out of the hospital by maybe 3 days or so. Now for our smaller kids or babies, probably kids under 15, 20 kilos, the kidneys won't fit there. Also, maybe their vessels are small, so they're placed actually intra-abdominally. So you're going to see a midline scar instead, and then the kidneys are hooked up to the aorta IVC. And so that recovery is going to be more like an XLAP, where there's more bowel stunning and ileus and so forth. Also, at our center, we place a ureteral stent, which is a plastic double J stent that spans the renal pelvis down the ureter to the bladder. Just helps to keep that anastomosis open. That's taken out by our urology colleague, Dr. Jessica Getz, at about 4 to 6 weeks afterwards. And sometimes, not all times, sometimes we have the original or native kidneys removed. And some indications include they still have persistent urinary reflux that could lead to more infections. Their old kidneys make too much urine, because you can have kidney failure but still have normal urine output or even polyuria, and we're worried that might cause dehydration that could lead to thrombosis. They still have severe proteinuria from the native kidneys, from nephrotic syndrome, that could increase the risk for volume depletion thrombosis. And sometimes, just refractory hypertension, they're on 4 or 5 medications, and a lot of times taking out the kidneys in this situation will help to improve that. So that's the surgical parts of the transplant. And then just quick blurb, immunosuppressive medications are really important. Like any other transplanted organ, the organ doesn't work without continuous medication exposure to calm down the immune system, prevent recognition and rejection of that transplanted organ. Our patients are typically on 3 drugs: tacrolimus, mycophenolate mofetil, or Cellcept, and then steroids. And so I always tell parents, don't let anybody stop your medications or change your medications without letting us know. And I think that's really just the key point, is make sure that if you have a transplant patient in your clinic, that you see these medications on their list, and if something needs to change, please just let someone on the transplant team know so that we can work with you. Now, the hospital course, on average, our kids are in the hospital for 5 to 7 days total, including a about 2-night ICU stay, and really just monitoring their kidney function and adjusting their medication levels. And then their recovery is mostly like any other surgical patient. They have to stool normally, but they eat and drink normally, make sure their pain is controlled, make sure they're walking. Like this guy's post-op day 1, he's ready to go, carrying his Foley urometer there at the time. And then the really important parts of the hospital, of course, are transplant education, making sure parents are comfortable with all the new medications their child is taking, the care, when to call us, and their discharge planning. And the follow-up as well, unfortunately, is pretty rigorous, at least in the beginning, but it's important because we want to make sure that we're leading, they'll have a good long-term outcome. But we see them twice a week in the first month, and then weekly for the second and third month. They get ultrasound, guided percutaneous biopsy of their new kidney at the 3-month mark, so they have to come back in the hospital. And with all these clinic visits, they get labs every single time. We don't have any better way to monitor kidney health or kidney function drug levels yet, so they just get stuck every single time, unfortunately, until some enterprising student in the audience, goes the Elizabeth Holmes route and invents, micro blood testing at home, but without the cheating and faking data part. No. And then even long-term, our patients are seen at least every 3 months with labs to monitor their kidney health. So it's a lot of work, but it is important for monitoring graft health. And we screen for infectious complications, signs of kidney rejection. They actually typically are silent, so we really depend on our labs. All right, so I flew through that, and a little bit behind my own timeline, but we'll see how much we get through, since also we have faculty meeting afterwards. So. All right, so what is our program? What's our role in pediatric kidney transplantation in the U.S.? And if you can see on the map here, actually San Antonio, we serve pretty much everything west of us, because our colleagues at UT Houston and Texas Children's, they're busy with their 8-9 million people in the Houston area. Same with the colleagues at UT Southwestern and Dallas and Fort Worth. There's a program, Driscoll Children's Corpus Christi, and they cover a lot of the Lower Rio Grande Valley, but there's nothing else west of us. And so we transplant everyone from our teammates in Austin, program in El Paso, as far north as Lubbock and Amarillo, all the way down to Laredo. So we get referrals from this whole area, which is important, right? Because we want to serve as many people as we can, in addition to serving the people of San Antonio and Bexar County. But it's a lot of work by my team, a lot of marketing visits, phone calls to build new relationships and maintain those relationships and their trust. And that's probably why a lot of our patients actually prefer our center to some of the other larger centers, because when they call, or when the physician calls with an issue, they know that we're going to pick up the phone. And from what we've heard from some people, some of those other centers, they don't always pick up the phone, right? And so when you're stuck out in the boonies with a transplant kid and they're sick and you got to know what to do, obviously you want to have that backup available. So kudos to my team for all that work that basically happens 7 days a week. And that culminates in our transplant program being a top kidney transplant program in the country. And that's been going on for years, actually, probably even before I showed up. But this is from 2024, showing pediatric kidney transplant volumes in the country. They'll say that a high volume center is doing more than 10 transplants a year. And out of probably at least 70, if not 80 active pediatric kidney transplant programs in the country, we have consistently been in the top 10, 15 over as long as I can remember, which is, and that's due in no small part to all the work that my transplant coordinators and the transplant team do. So, and when you do this, when you're performing this well, other programs notice, other people notice, and so it's led to a lot of great collaborations with other centers as well. So. Also, you can't just do a bunch of kidney transplants without having good outcomes, and so we are monitored directly under the Department of Health and Human Services. And but we've met or exceeded benchmarks set by them pretty much every year, and the popular the common benchmarks being patient and graft survival at 1 and 3 years, and we've done exceptionally well pretty much every year. So once again, this happens because of our hard work of our team. All right, so things still aren't perfect though. So what are some other issues we've tried to tackle to improve our care of our pediatric kidney transplant patients? Some common themes that pop up include, addressing the donor shortage, improving the long-term outcomes, and can't talk about chronic illness without talking about teenagers. But so at University Health Transplant Institute, we've really focused on increasing and promoting living donation, not just for kidney, but also for other organs, for liver as well, in both adult and pediatrics, because that's going to be one major way to help fix or help decrease the burden of a donor shortage. This graph shows here that over time, the total number of transplants we've done in the country have increased dramatically, which is great. That's fantastic. But this gray line here is the number of living donor transplants. And sure, there was a little bit uptick here, and then COVID didn't help, but definitely has not increased as much as the deceased donors. So this is something that we should work to improve. And on the pediatric side, it's the same story. This graph here shows that over time, living donor kidney transplants have a better survival compared to deceased donor in purple, but compared to the number of deceased donor transplants happening, the number of living donor transplants has not increased over time. And so recognizing this, the instituted a program, started a program called the Champion for Life program, knowing that, if somebody has kidney failure, how many of them are going to be brave enough to go out there and, put it on social media that their kid needs an organ, or how many of our patients have the means to put up billboards around town saying, hey, I need a kidney or I need a liver. So this team basically helps families do that, helps them to tell their story and get the word out there, so that they're more comfortable, and so that even maybe their neighbors or their loved ones are aware that, oh, I know this person, they have kidney failure, maybe I can help because I'm healthy. So and it's a lot of work, it's a lot of calls once again, but it's culminated in a lot of great stories. You remember Emmy from earlier, her donor, Lori, is actually one of our own transplant coordinators. They saw her story and decided to get tested, and it was a match and donated to her. This young lady here showed up at another hospital emergency room with a cough, and then her life changed overnight. She was actually found to be in kidney failure, had to start dialysis right away. And once we got her story out, over 100 people from her hometown signed up to be screened to be a potential living donor, and she eventually got transplanted. There's another famous patient of ours here, Matthew. He was a baby born that had kidney failure soon after. He actually had a transplant initially, but it failed earlier than expected, unfortunately. But then as he was looking for a second kidney, his story got out there, and his first grade teacher actually ended up being a match and ended up donating to him. And finally, this little boy here came all the way from El Paso because we found a donor, an unselfish donor, called altruistic donor from around here, who was willing to donate to any child who was in need, and he ended up being a match. And this was at an event we call a living donor reveal, where recipients get to meet their living donors if both parties are willing. So a very touching and tear-filled event. And also with all that work, it's led to something that I'm still most proud of that our program has accomplished so far, which is back in 2022, our program did the most pediatric kidney kidney transplants in the entire country. The amazing feat for our relatively smaller program. And what happened with all the hard work of our coordinators and our teammates, and support from transplant leadership. And we didn't quit there. And actually in 2024, as data just came out, we did it again. We're basically right there at the top with Leary Children's, Cincinnati Children's National. And this is all because of the hard work of our team. So, and once again, when you do this, people notice, programs notice. This was an oral abstract presented at our national transplant conference, the American Transplant Congress, back in 2023, presented by one of our fantastic surgical residents, Kelly Harrell, and the team, and basically outlining, how did we grow our living donor transplant program, because other programs had tried and failed and they want to know. So so it's a great way to get our name out there in the community, in the country, and also build new collaborative relationships. So who can be a living donor? It's basically anyone who is healthy. You can be healthy and be a badass like our own Dr. Kelly Hitchman here. Sorry, I said badass. I said it twice now. Dr. Kelly Hitchman is our HLA lab director. So she's basically the gatekeeper. She in terms of making sure that our donor and recipient pairs are going to be a good match, a safe match. And working with our team and our population, she's seen the great things that we were doing. And was inspired herself to unselfishly donate an organ to somebody in need. And so she did that. And then, because she's a badass, promptly climbed Mount Kilimanjaro with another team of donors just to prove how awesome she is. So, but you don't have to be that awesome to be a donor. You just have to be adult, healthy. If you're going to donate to someone, you don't have to be a blood relative. And actually, a common myth is that they're going to take your kidney and run away with it. You actually can dictate who you want to donate your organ to, or if you just want to donate to anybody in need. And the benefits of living donation include you're getting someone transplanted, so you're getting them off the list, getting them off dialysis earlier. You're also freeing up a spot on the transplant waiting list, because that kidney that may have gone to them now is going to go to somebody who is waiting because you got a kidney from a living donor. So, and as I've shown before, they have better transplant outcomes overall. And it's been shown time and time again that actually donors basically have a normal life after they donate. So please go find someone in need and sign up to be a living donor. But if for some reason you can't, you can always register to be an organ donor as well. And you can do that through the donatelife.org website. Also, you can do it at the DMV when you're renewing your license. I didn't know this. You can actually do it when you're getting or renewing your hunting or fishing license. So, and then finally, you can do it through your iPhone Health app as well, too. There's a way to sign up that way. All right. So what about improving long-term outcomes? We've shown time and time we're really good at getting kidneys in our kids and having them survive and do well the first few years. But how do we extend it out into 20, 30, 40 years? Right? Things that affect long-term kidney outcomes include the quality of the donor itself, donor organ itself. And fortunately for kids, they are actually prioritized for the least damaged or best quality donated kidneys. HLA matching, like talked about, preventing graft rejection, and then medication adherence. So I'm going to be talking about teenagers, right? So in terms of matching, so when you're trying to see if a donor and recipient pair are a compatible match, we do something called a physical cross match, where you basically have the serum samples of the two parties to see if there's a reaction. And if there is, then you don't transplant that pair. But if there isn't, then you proceed. So, however, and that's very simplified, by the way. So, but however, that testing takes time too, and so that's probably another 4 or 5 hours waiting with the donated kidney out of the body, either on ice or on a pump machine, before you can get transplanted, which leads to potentially more damage. And so, how do we make that better? How do we shorten that time? And so in the adult world, they started, once they're able to characterize patients' HLA profiles or patterns through software, they started doing this testing actually virtually. And it had been shown that doing that testing virtually very closely matched the results you would get from the actual physical test with the blood samples. But it's much faster, obviously, because you don't have to wait for the blood sample and wait for the test. And there are a couple other pediatric centers doing it in the country, but no one had published this. So we said, well, we're doing this. Why don't we just compare and see what we've got in the past? So we looked at our historical cohort in the light blue here, where they had just traditional physical cross matching, and compared it to our patients using this what we call virtual cross matching software, and seeing how they did over time. And we found that there was no difference in their survival, and also no difference in rejection. So basically using this virtual cross matching or software method of matching patients we showed it was safe in kids too. So, and like I said, the other centers are doing it. And we actually have this was presented at the American Transplant Congress and National Transplant Conference last year, and actually won best poster for that session. and we have an updated data to send for this year's conference as well too. What about graft injury monitoring? So our traditional test for kidney health is the creatinine, right? So, but unfortunately, it's sure when it's abnormal, it's pretty specific that there's some type of kidney problem going on, but it's not the most sensitive test. It doesn't change that quickly.
I lost the thing.
Okay,
Shit.
if you just logged on, if you could please mute, please. But otherwise, so it's a basically a late marker of kidney injury. So in our search for earlier markers of injury to our transplanted organ, we're actually using relatively older technology, which is decades ago they discovered that there is some cell-free DNA, this free DNA floating around in the plasma called cell-free DNA, and then eventually people found, researchers found that there's also, when you have a transplanted organ, there's also free-floating DNA in the blood from that organ as well, and found that when there is injury to that organ, say a kidney, that that amount of free-floating DNA from the organ seems to rise. And so they started using that test as a marker of injury to a transplanted kidney and found that when it's high, that means that there's likely some kind of injury going on and probably rejection. And so we were one of the first, and we published this a year or so ago. We're one of the first centers to demonstrate this, in addition to colleagues out of UT Houston and Cedars-Sinai and WashU. So if you're looking at cell-free DNA percentage here, in our patients who were quiescent or had no rejection, they had basically normal levels of donor-derived cell-free DNA, which typically we'll say is less than 1%. But our patients who had some kind of rejection had significantly higher levels. And also we showed that when you had rejection, it was high, you did a biopsy, and then you started treating them, we actually showed that that marker would actually improve. So as a marker of hopefully adequate treatment. And so there's been a wealth of additional research on this marker plus additional markers, and we're continuing to work on this as well in our population. But we're just searching for earlier and earlier markers of graft injury, kidney transplant injury, because creatinine is just too slow. So, all right, teenagers. So one of the most common cause of long-term graft dysfunction or late rejection is incomplete or complete medication non-adherence. You miss a few doses, your drug levels go down, the immune system ramps up and starts to recognize the foreign body, which is a transplanted organ, and then leads to rejection and a decreased life of the transplanted organ over time. So not unexpected. Studies from the prior have shown that adherence is high in teens, over at least over 50% in some studies, more common in teenagers compared to younger children. When they've done surveys to figure out, well, why is this happening? Actually, unfortunately, lack of parental supervision was one of the most common reasons. Parent-child conflict, right? So all the normal teen things that they go through affects their medication adherence too. And so just ongoing ways to try and improve that, which I have some subsequent slides. But in the meantime, how can we potentially monitor for that? So this is a study by Dr. Kim Pyburn, our own colleague, and one of our recently graduated residents, Rohit George, who's actually a nephrology fellow up at UT Southwestern now. So Dr. Pyburn had published on the variability over time of our tacrolimus drug levels and that association with the development of antibodies as a marker of the immune system starting to recognize the kidney and causing damage. And so they hypothesized, well, if we use that high variability level plus high levels of that free-floating DNA or cell-free DNA as markers of risk for developing rejection, meaning developing these antibodies that could cause damage to the kidney. And they found in their pilot study that those patients who had low variability, meaning consistent drug levels, or low levels of cell-free DNA, they did fine. They didn't develop these bad antibodies. But those who had high variability, indicating inconsistent or incomplete medication taking, and a higher level of cell-free DNA, that was highly associated with developing antibodies and likely rejection. So that's one way to screen for who's doing badly before we actually see evidence of damage, meaning creatinine change or something else, to try and catch these problems and fix them as early as possible. All right, so moving into teens, so how can we better support our teens? Because our goal is to get all of our teenagers with chronic illness to become healthy young adult patients with chronic illness, right? So, but it's a significant challenge, and we've known this for decades. This is one example of study 10 years ago, looking at 10-year graft survival over time by age at transplant. And this, of course, this dip here is our teenagers, unfortunately. So patients transplant teenagers did worse over time compared to younger or older patients. And once again, why is that? They even did this study actually has one of the best titles I've seen in the paper. So they were surveying young adult patients to see if they were adherent or not, and 2/3 report that they were taking their medications consistently, but by testing, actually 2/3 were not taking their medications consistently. However, when they did their quality of life testing, they were very happy. So hence the title, Young Adult Transplant Patients Not Adherent and Happy. Also, this is a pretty off-sided study looking at brain imaging imaging of the brain and maturation over time. So for simplicity's sake, the purple areas are more mature areas of the brain, and this is over time by age from 5 to about 20 years of age. And they showed that neuromaturation goes on and on, actually into the 3rd decade of life. The areas that develop earlier are vision, hearing, and motor, but the important areas for executive functioning, the frontal lobes, the prefrontal cortex, actually develop last. And these are important functions related to planning, problem solving. So basically all, keeping a teen from doing something bad, keeping a person from doing something bad and making bad decisions, right? And they've used this as an argument for, well, even our young adults aren't ready to handle some of these issues on their own. So as pediatric doctors, should we be sending these patients into the adult world and seeing them fail right away? So that's been an ongoing battle, but also is an important point when we're talking about adolescent young adult clinics and inpatient units to help support them, because I believe they need help still. So at our center, I'm gonna move along real quick here since down to 15 minutes. So at our center, we did we're trying to figure out what had happened to some of our prior graduates into the adult world after kidney transplant. And out of about 85 recipients, we were only able to find out the status on about 28. We were able to reach 13. We found out, unfortunately, 2 passed away at the time we'd done the study, and then got the status on another 13 patients. And it was pretty sad. Unfortunately, about of the 13 patients who had failed kidneys, 9 of them were still on dialysis at the time of the survey. Not all of them were relisted for transplant, so I had to figure out why, and only 1 was retransplanted. And then just asking about their basic, their general life. Most of them were still living with their parents. A small proportion of them were employed, and a lot of them had comorbidities that adults typically have with chronic illness, hypertension, diabetes, but also mental health issues, with the most common being anxiety, depression. So it's kind of a sad picture to see. And once how do we better serve this population is still a work in progress. So one thing we're doing is using this tool developed by Dr. Maria Ferris and her team out of University of North Carolina. Basically, we assess them at each visit to find weaknesses in their understanding of their illness, their medication, their health management, reproductive health, so that we can have our team members work with them on those specific issues with the hopes of training them to be a successful young adult transplant patient. Also, we have a monthly pediatric organ transplant support group. So teenagers with both kidney and liver transplants, they meet with, it's run by one of our psychologists, Dr. Elliot Lopez. And basically it's a safe space for our teenagers to come and hang out. They share their stories with each other, and probably air some of their grievances as well. So, and still trying to find a way to turn this into a research results as well. But in the meantime, that's what we're doing. Another thing we're doing to try and help these teenagers cope with having a chronic illness for the rest of their life. All right, last set of slides. So what's the future? What am I hoping that our program can be involved in going forward? Because it's either coming or it's here. And I forgot to take this out. Sorry. But and then with the recent merger with UTSA, does that open up some additional opportunities for some of these? So everyone's read about pig kidney transplantation, or transplantation in the country is very prominent in news, and for good reason, because it's brand new. And researchers have worked on this for decades, but one of the major limitations was, you're taking an organ from a different species, right? And so with that comes antigens that our bodies would attack and damage the grafts, and also zoonotic infections that could potentially cause trouble in the human recipient. And the real breakthrough for moving this forward was CRISPR gene editing, because where in the past, when you're trying to gene edit an organ, it would take years to breed those animals and organs, but now with CRISPR gene editing, it takes months. And so that's why things have moved more quickly in recent time. So, the first transplant, pig to human transplant, was done at Mass General about a year or so ago. Unfortunately, that patient only lived about 2 months, but actually didn't die from the transplant process, died from cardiac disease. And then this patient in this article here from January 25th of this year, I believe this was an NYU patient, got an organ and so far admitted through now 3 months. And then surgeons at Mass General just performed the second transplant just about a couple of weeks ago. So like I said, it's here. The FDA has cleared the path for clinical trials, and both UTSA and UT Health San Antonio have advanced animal research care facilities. So hopefully that's something that we could explore in the future. Another novel therapy was sequential stem cell and kidney transplant. So if you get a stem cell or bone marrow transplant from a donor and then get an organ from that same donor, you actually don't need any immunosuppression, right? Because there's no foreign body, there's no foreign tissue anymore. And it's been done sporadically, and this is just one example in a specific pediatric population, actually by Dr. Pyburn's old mentor, Paul Grimm at Stanford. So they had these patients with a rare immune deficiency, Schimke's, I forget what it's called. Someone will, Dr. Infante will tell me. But yeah, so they have this T cell deficiency, and then they actually die from infections and kidney failure. And so they were able to initially do a haploidentical stem cell transplant for these patients from a donor. And then afterwards, after the transplant engrafted, then they would do a kidney from that same donor. And these patients did not need long-term immunosuppression, and their kidneys so far have done well. So the hard part is, though, how do you do a stem cell or bone marrow transplant without killing the patient, right? Because it's a lot of conditioning, and there's a risk for infection, also the risk for graft versus host disease afterwards. So that's one of the main barriers still. So, all right, I'm going to fly actually CAR T therapies here as well. So training our own cells to attack bad cells in our body. And in the case of transplant, when you get rejection, you're going to have memory cells making these bad antibodies that attack the donor, the transplanted kidney. And so using CAR T to get rid of those cells is here. We're still looking for additional biomarkers, not only for looking for graft injury, but also as markers of monitoring graft health. If this tested normal, yes, your transplant organ is likely doing well. And then for rejection monitoring and treatment and monitoring as well. So if we have, say somebody has rejection, how do we know that we've adequately treated? Because the only true way to diagnose rejection and know what's going on in the kidney is to do a biopsy every single time, which is definitely not easy for a small screaming child, right? So are there other biomarkers we could use as a alternative, what we call liquid biopsy, that would tell us exactly what's going on? And so there are a lot of active research in those fields too. And finally, probably pretty far off, but researchers have also worked for decades with pluripotent stem cells, trying to grow organs like the kidneys. I don't think we're anywhere close yet, but once again, UTSA and UT Health have 3D bioprinting capabilities, so something potentially an enterprising student could explore in the future. So, all right, so I'll finish with the last couple of slides. So we all know that everything, everything we have now, we've gotten this far because of our predecessors, they were willing to get their hands dirty and toil away to make sure that their patients were better, but also to advance the field. And so that's the mindset of our team as well, is, what can we do to continue that our patients are getting better, and make sure that the next generation of doctors and medical providers doesn't repeat the mistakes that we'd made. And then finally, none of this happens without the entire team. So this is probably most of the Transplant Institute. It was a pretty good turnout. Without the vision of Dr. Sigro and Dr. Half and our transplant leadership, they ingrained from the beginning in our culture that pediatric transplant was important, and that's why we've had the success we've had, because they supported us the entire way. So, so anytime you see a transplant team member, please say hello, recognize them, because they're working 24/7 to make sure that our patients with organ failure have a chance at a normal life. So, and I'll finish there.
Thank you, Dr. Ranch, for educating us on kidney transplants and other issues related to them. Let's see, we have 5 minutes exactly for the discussion. So anybody has any questions, comments before we go to faculty meeting?
Dr. Ranch, I have a few questions for you, if that's okay.
Yes, sir, Dr. Sanders.
Good morning. Thank you for a great presentation.
Thank you.
In regards to like adherence with a medication after the transplant and the teenager group, you obviously talked a lot about that. Is there any like ongoing like research in that area as to things that might help improve that? Because that type of research could reach into a lot of different areas as well with medication adherence. And then the second question, it's a little further out there, but is there ever going to be an artificial kidney?
Great questions. Thank you very much for those. So the first question, yes, there's, we've tried everything, and you're right. It's not just transplant and teenagers, it's any chronic illness. And I'd shown that in the previous talk, where it's our patients with diabetes, lupus, asthma, cystic fibrosis. How do we successfully get them into adult care without them dying? Years ago, I proposed trying to start a multidisciplinary transition clinic where basically teenagers would come for training to become good patients. But obviously, there's a lot of logistics and funding barriers to that. But that's something that some centers have done with varying degrees of success. Ongoing technology type research projects, pill bottles that have sensors, so they can be tracked when they're opening. People try to think of pills that actually contain the sensor, so they can actually know when patients are actually getting the medications into their bodies. Trying to find other ways to monitor drug levels at home versus having to come to the lab every time. All different things that people tried with varying success. So definitely a lot more work to do. So. And for your second question, artificial kidney, that research has kind of gone quiet. One of my mentors actually was involved in a project years ago, where it's basically a small implantable device that would go in the leg and hook up to the femoral vessels there and drain it, and the fluid actually drain into peritoneal cavity, but basically provide enough dialysis without an external machine or catheter for about 3 to 6 months, and people will just have that device reimplanted or exchanged out every 3 to 6 months. And when they did a survey at the time, patients definitely preferred that to having a catheter or fistula and coming in center for dialysis. So, but that kind of went quiet. And I think two of their issues, one was clotting, right? Because it's a foreign body hooked up to the vasculature, and two, just getting adequate filtration with the technology they were using. So I'm sure the research is ongoing, but I haven't heard any updates since.
Awesome. Thank you very much. Appreciate it.
Thank you.
Any other questions, comments? We have 2 more minutes before we go to faculty meeting. I don't see anything. So Dr. Ranch, thank you very, very much for educating us regarding pediatric kidney transplants. Thank you all for attending this morning's grand rounds. We'll see you again next Friday at the same time. Please join the faculty meeting, which will start in about 2 minutes. Thank you. Have a wonderful
Thank you, everybody.
Friday, wonderful weekend.